Okay, so good evening everyone. So Dr. Deepak, Dr. Mahesh, Dr. Easy Medical, good evening all of you. Dr. Mastak Saglin, congratulations, I keep your message, okay? I discuss with everyone. So congratulations for your FMGE success, okay? So well done to all the students over there. Let me start with the session now. So if I'm visible and audible, everyone? I could hear myself though. Yeah, okay. So let me just go forward and start with the session right now. So continuing with the same thing. All right, so there are old people who are already there. For the new people, just let me introduce myself in 5 minutes. By then we'll wait for other people to join in as well. So as many people are there, it will be much better. So just to introduce myself, my name is Dr. Vinish Srivastava, presently the head of the department and associate director of anesthesia and critical care. I'm working with the Fortis Lafam Hospital in New Delhi. Prior to that, I was a senior consultant here itself at this Fortis Lafam Hospital for the last 8 years. Prior to that, I was at Maulana Azad Medical College. I was a senior resident over there. I was also a specialist over there. Before that, I was at Deen Dayal Upadhyay Government Hospital, New Delhi. I've done my DNB secondary anesthesia from there. Prior to that, I was at Grant Medical College, JJ Hospital, Mumbai. I've done my DA and FCPS anesthesia from Grant Medical College, Mumbai. Before that, I was at Lokmanya Tilak Municipal Medical College, Sion Hospital, Mumbai. So I've done my respiratory medicine from there. I'm also qualified chest physician. Before that, I've done my hospital administration. And before that, MBBS. So that was a slight introduction about myself. So Dr. JJ is asking me, how is anesthesia for a guy with mild essential tremors? It's okay, Dr. JJ, if you're confident enough of intubating someone and giving a spinal, not an issue. Okay. So I have had patient or people, my juniors also, who kind of have tremors, but they're able to manage things well. Okay. So don't worry about it. Just have to be confident of doing your practice with the work that you're doing. All right. So going forward, guys. So apart from clinical duties, I tell everyone to keep a hobby. For me, it's playing the guitar. Apart from that, also been teaching students preparing for postgraduate medical entrance exams and FMGE exams for the last 10 years. Now associated with Unacademy. So people who haven't followed me up, do follow me up. People who haven't downloaded the app, please download the app. You have to use a code to log in. Any code that you have will help you with that. Once you log in, open it. And there are two things which is most important. One is the plus, which is basically the subscription based, which is useful for people preparing for long term. And special classes, the third one, which is totally free. This is basically where we discuss MCQs. I just finished one about 15 minutes back. I'm going to take another one at 7. And here we discuss all MCQs, just like the one I'm discussing on YouTube right now. Okay. So guys, the point is the special classes, which are totally free, again, are just like the plus ones, where you have interactive live classes. There are polls, raise a hand feature, never miss a class, lecture notes, anytime, anywhere. Just like the subscription based ones. The subscription based ones are what we suggest to people who are preparing long term, because it got live and recorded lectures both. You compete in the live tests and quizzes, there's question bank, and you study on the device of your choice. So this is basically for people preparing long term who are just studying now. Okay. Iconic is something which has Unacademy and Prep Ladder both. So it's best of both the worlds available. Okay. So these are the places where we do complete courses. The question bank is highly effective, guys. It's more than 25,000 questions and with detailed explanations that is there. Okay. So congratulations to all the toppers. People have done very well in FMG exams, and the other people who are just clearing it out, I want your names also to be here. Okay. Feels good for everyone to see that. Raise a hand feature is available in all the live classes, guys. This one test which we just finished, All India mock test, I've recorded all the answers for that, the detailed explanations for the questions which have been set up. You people can go through that. It's been recorded. So you people can see, all the people who have appeared can go and see through this All India mock test. I've given the explanations to the anesthesia questions. Okay. So notes for NEET PG, new thing coming up. Also, there's a price hike coming soon. People who want a subscription should go ahead for that as fast as they can, as early as they can. All right. Keep your dates. Do follow us so that you come to know when the next test series are going to be held, so that you can take part in them, which are totally free. Okay. These are the new what you call the batches which are running. So NEET PG 2022 previous year question batch starts from March 2, 2-month course. Focus FMGE 2022 starts from March 2nd. All right, same Focus FMGE batch. Target Next 2023 batch, okay, starts from March 2nd. So these are the new batches going in. And NEET PG 2022, there's an all educator revision batch. So all of us are going to take lectures over there. So these are the new things. Okay, so let's start with the session, guys. People who haven't followed me up, do follow so that you come to know when my next sessions are being held. All right. So without wasting any more time, let me just go forward. Okay, so this is what we had already done. We'll discuss from where we left yesterday. So we had finished off some questions yesterday. So let me go forward and begin it from there. I think all the people have joined in. So let's start from here. So local anesthetics, I think we have finished off this part before this. This we have finished off. Let's start here. Local Anesthetics Act where? Dr. Julie, that we have done, we discussed yesterday. Local Anesthetics Act at A, B, C or D. Dr. Abhi has given an answer. Other people, please do mark your answers. So I'll just try to keep it over here and it's visible to me. Arey, there are so many of you. I got only four people giving me the answer. Other people, fast. There's so many of you there. Even if it is wrong, just mark your answer. Okay, so all right, so most of you have given me the answer. The people, all of you who have given me the answers are correct ones. You're absolutely right. Sodium channels. Okay, this is where the local anesthesia drugs action takes place. So remember, whenever you give local anesthesia drug, okay, so Dr. Vinod has given A, Dr. Deepak says C. C nahi, Dr. Vinod, Dr. Deepak, the correct answer is A, sodium channel. Okay, sodium channels are the correct answers. Remember, all of us, when we have given local anesthesia drug, where did you inject it? Remember, local anesthesia drug was injected inside the tissue. What happened is, from the tissue, the drug gets absorbed. Okay, from the tissue, it gets absorbed inside the nerve. This is where the effect takes place. So therefore, the effect of the drug takes place at the nerve, and inside the nerve, there are these sodium channels. This is where the effect takes place. So whenever you give local anesthesia drug, basically you've injected in the tissue, but from the tissue, the drug gets absorbed inside the nerve, and in the nerve, it's a sodium channel where the action will take place. All right. So if this is the nerve, routinely what happens is, if someone has sustained an injury, किसी को इधर चोट लग गया, so what happens? Action potential is getting generated. This is going forward. Okay. So this is basically going forward to the spinal cord. From here, it's going to go to the brain, because of which the patient is feeling the pain. All right. The action potential basically is going forward like this. It's going propagating like this. This is how the action potential propagates. So what is happening is it's propagating or going through the nerve. Now, when you get inside the nerve, what will happen is there are these sodium channels. So action potential comes here. There's a sodium channel. It jumps over. Next sodium channel. Sort of, 3 of them are there basically. Nodes of Ranvier that you people know. So it kind of jumps from one to the other place. So here what will happen? Action potential is coming or going along through the nerve. This is the sodium channel that you see. So sodium goes inside and this jumps to the next one. Action potential has jumped to the next one. Sodium goes inside, it jumps to the next one. Sodium goes inside, it jumps to the next one. But in case if I've given local anesthesia, can you see what has happened? Now the local anesthesia has blocked that sodium channel. Okay. So therefore what happens is, when you have given local anesthesia drug, so initially the action potential came here. All right. Sodium went inside, the action potential went forward. Sodium went inside, action potential went forward. Sodium went inside, it went forward. But now local anesthesia has blocked it. Okay. So Dr. Julie says it is time gated ligand. So there are three things involved, Dr. Julie. I think you have to go into details of that. It also depends. There are three types of nodes which are there. Okay. So it is time related also. It also is related to the amount, whether it is what state it is working in at that point of time. Okay. So just remember, basically it is blocking these channels. Because of this, because the channel gets blocked, further sodium doesn't propagate inside and the action potential stops right here. Therefore, yesterday's question which we had discussed, okay, conduction block, if you remember we were discussing this point, which one produces conduction block. So when you give local anesthesia drug, it is doing the same thing. It is preventing that conduction going forward. That is exactly why it is also called as conduction block, because the conduction which was happening is not taking place. So you can also call it a conduction block, or you can call it a propagation block. Okay, that's exactly how local anesthesia drugs work. Another point is, when you will see how local anesthesia drugs work is, if you see from the diagram, can you see the block when it takes place? It happens with a local anesthesia drug going inside and then working from here, cytosolic side. It doesn't happen from here itself right at the top. Okay, therefore it has to penetrate the lipid membrane and go inside, and that's exactly why local anesthesia drugs lipid solubility is related to the potency of the drug. If the drug is more lipid soluble, it is more potent. So therefore local anesthesia drugs potency depends on lipid solubility. More drug soluble means more and better action, and you will get a better effect. Thumbs up all of you. Clear? Okay. All right, so this was, in short, we discussed few things about the local anesthesia. All right, so let's go forward. We have an image right now that we'll see. So what does this indicate? Thyrotoxicosis, esophageal intubation, asthma, none of the above. D, A, B, C, D. So I'm getting different answers. Dr. Andy is given one answer. Dr. Andy, Dr. Julie, Dr. PK. Right. So all you guys are absolutely correct. Okay. The people who have marked it as D is totally correct. So this should have been, basically, instead of none of the above, the correct answer would have been patient breathing spontaneously. Okay. Patient breathing spontaneously. All right, so that is correct. If there is curare cleft, that is also the right thing. So basically what you are seeing in front of you is a capnography. Okay, this is a capnograph. All right, what is a capnograph? So guys, capnograph is a graph of carbon dioxide coming out. So this is called capnography. It's a graph of carbon dioxide coming out. It's also called as same thing as EtCO2, which means it is end tidal carbon dioxide. Normal carbon dioxide in the body, PCO2 is 35 to 45. So therefore the value of EtCO2 is approximately the same as PCO2. So normal value of EtCO2 is 30 to 35, which is the same thing as PCO2, which is 35 to 45. Okay, so normal EtCO2 should be between 30 to 35. What is capnography, guys? Whenever someone leaves out carbon dioxide, you get a graph like this. Okay, so this tells you about expiration. Carbon dioxide has come out. This is inspiration. Then carbon dioxide has come out. Expiration. Someone is breathing in, inspiration, oxygen. Carbon dioxide coming out. So whenever it is going down, it means it is inspiration. Dr. Julie, wait, I'll explain that. Spontaneous and rebreathing are not the same. I'll explain that. Just wait, hold on. Again, when the graph goes up, it is carbon dioxide, and when it goes down, it is inspiration. Expiration, inspiration, expiration, inspiration. So this is what is seen in IPPV when you give positive pressure. But if we are breathing on our own and we keep a graph, will we get a graph? Yes. In that case, this is expiration, inspiration, expiration, inspiration, expiration, inspiration, expiration, inspiration. Whenever the graph goes down, remember it's inspiration. This is what is seen in spontaneously breathing. Now, If you get a graph suddenly like this, means no carbon dioxide coming in. This is what is seen in esophageal intubation. Okay, so basically this is what is seen in esophageal intubation. This is what is seen in disconnection from the circuit. This is seen in accidental extubation. The same thing can be seen almost in embolism, cardiac arrest. Now, this means there is no carbon dioxide coming. Suddenly you have got huge amounts of carbon dioxide coming out, which means lot of carbon dioxide is getting released, or more carbon dioxide is there inside the patient. More carbon dioxide, more and more carbon dioxide, huge. See, the graph should have been like this, but now it's become huge carbon dioxide coming out. This is what is seen basically in thyrotoxicosis, more carbon dioxide production, or any condition which leads to more carbon dioxide production. Okay, thyrotoxicosis. You might see it in malignant hyperthermia, sepsis. Okay, you will see it in laparoscopy. When we do laparoscopy, carbon dioxide increases. All right. Dr. Andy, that is the value 35 to 45. Can't actually pick up the same thing now. If you want to know the blood gas values, that is 35 to 45. Okay, Dr. Andy, 35 to 45 is the PCO2. All right. PaCO2 in the arterial blood. This is what is coming out in the breath. It's approximately the same. That's what I said. I've mentioned it approximately. It's not the same. But it's approximately the same. We consider it to be the same. Okay. Yes, Dr. Andy. Clear? Now, we were discussing about the thyrotoxicosis, malignant hyperthermia, sepsis and laparoscopy, where carbon dioxide is increased. Carbon dioxide also increases in rebreathing, as Dr. Julie has said, right? So in that case, what will happen? You will get a graph like this, but in that case, the graph does not touch the baseline. If the graph does not touch the baseline, this is what is seen in rebreathing. Thumbs up, Dr. Julie. Is your point clear now? If someone is rebreathing his own carbon dioxide, you get more CO2, but the graph does not touch the baseline. This is how you separate, or you come to know how rebreathing is different from laparoscopy, malignant hyperthermia, sepsis, fever, thyrotoxicosis. Dr. Julie, is your point clear? Yes. Okay. Now, then asthma. Now carbon dioxide is coming out, but ruk ke aa raha hai. It's not coming full. It's come slowly. It's come slowly. It's coming like this. Means yes, it is coming. It's not like this graph here where there is no carbon dioxide. It's not like this graph where it is increased. So it's a graph where it was expected to come normally, but it is coming slowly and slowly. This is what is called as a shark fin afference. Shark fin, which is seen in obstructive diseases. Or basically I would like to put it in this way, COPD or bronchial asthma will show it. Right? So this is what we have seen as all of capnography. But what is it which was asked to you? What we have discussed. So what we have discussed is, now I'm just trying to take all these things away. Sorry. Just give me a second. Okay. So now what we had in the graph which I had asked you was like this. What does this tell you? This is what was asked right now. So basically what this tells you is there was IPPV coming, IPPV coming, IPPV coming, IPPV coming. So in that IPPV, what was happening was expiration, inspiration, expiration, inspiration, expiration, inspiration. Expiration, patient tried to inspire. Expiration, patient tried to inspire. Expiration, patient tried to inspire, and now patient is breathing on his own. Did you realize? Patient was in IPPV and the patient is trying to breathe. Whenever the graph is going down, means the patient is trying to breathe, which means patient from IPPV is going to spontaneous, khud se saans le raha hai, which is like this. It's going to happen like this in some time from now. Okay, so therefore this what you see over here is called as curare cleft. The meaning of that is that patient is trying to breathe spontaneously and coming out of the muscle relaxant effect. So therefore if the surgery is going on, repeat muscle relaxant, or if the surgery is over, then you try to extubate the patient. Thumbs up all of you, because after a while the spontaneous breathing will become like this. Thumbs up everyone, point clear. This was the graph which we discussed right now. Alright, thumbs up everyone. Okay. Hopefully, since you're not asking, I'm not got any responses from anyone as such. Dr. Dawood gives an answer. Okay, cool. Dr. Julie also. Let's go forward then and take another question. Hopefully all your doubts here are cleared. Okay. So let's go forward. Alright, so which of the following is safest to use in a patient of bronchial asthma? Atracurium, thiopentone, desflurane, ketamine. So you have all types of anesthesia medicines. Okay. You get a patient of bronchial asthma. It's not related to one drug particular per se. You get a patient of bronchial asthma. Which of the following drugs is safe? Of the ones that you're seeing in front of you. So as I see Dr. Vinod, Dr. PK, Dr. Andy Sky, other people, I said I'll wait for 30 seconds. Let me wait. Till the time you guys mark the answer. Dr. Deepak. Arey, so many of you are there, other people. Dr. Andy, I'm coming there. I'm just waiting for the people's answers to come in. Okay, so let me correct. See, the people who have marked the answer, all of you, in fact, all of you, the ones who have marked the answer here told me ketamine is the correct answer. When you speak of atracurium, remember atracurium has histamine release. Okay, because it has histamine release, it can cause bronchoconstriction or bronchospasm. Thiopentone, guys, remember again has histamine release. Okay, so remember atracurium, and in fact that is the reason when you speak of thiopentone and you give it to a patient, you get two things. You get pruritus, MCQ question. At the same time, it can also cause bronchospasm in the patient. Thiopentone. Okay. When you speak of atracurium, because it has got histamine release, that's exactly why it is contraindicated in a patient of COPD or bronchial asthma. You don't prefer to use it because of histamine release. Desflurane, it's pungent to smell. It's an inhalational agent. It's a pungent and it causes bronchial irritation. And because of bronchial irritation, this itself can cause bronchospasm. Therefore, when you speak of these drugs, atracurium, it has got histamine release, thiopentone, histamine release. Desflurane being very, very pungent, it has got, in fact, the maximum bronchial irritation out of all the inhalational agents. This was again an MCQ question in 2019. Okay, NEET PG only. Maximum bronchial irritation is seen with which one? Desflurane. It can cause bronchospasm, so these three are not to be used in a patient of bronchial asthma. On the other hand, when you look at ketamine, it is one of the best drugs for the respiratory system. In fact, a patient who is undergoing, active bronchospasm, this is one of the best drugs because this can also be used to treat, in fact, books have mentioned as status asthmaticus also. Because what happens is, ketamine is a very, very good bronchodilator. Correct? So Dr. Andy Sky said that it's a very, very good bronchodilator. Because it's a good bronchodilator, some books have even suggested that it can be used in status asthmaticus. Alright, so it's such a good drug. So therefore, in a patient of bronchial asthma, the safest drug out of the ones which are given here, out of the four of them, ketamine is the one that stands out. It's a very, very good bronchodilator. Okay? Very, very potent, in fact. Alright. But the point is, if I give you just in terms of, let me ask the same question in another manner. A patient with a history of bronchial asthma is to be given GA. Okay. So which of the following is correct regarding that, or which of the following can be used? Okay, so let's put it like this. A is ketamine, B is propofol, C is both, D is none. Yes guys? Which of the following is correct regarding the induction in this patient? Okay, so that's how questions come. Did you see? We made a question here itself. That's exactly what I've been doing yesterday also. Alright, so Dr. Andy Sky has given an answer. So please read the question and try to tell me. A patient with a history of bronchial asthma is to be given general anesthesia. Which of the following is correct regarding the induction in this patient? Which of the drug can be used? Ketamine, propofol, both or none? Of course, I think none would be, everyone will agree with me, it's not none. So it's going to be normally A, B or C. Right? So Dr. Andy Sky, Dr. Deepak, Dr. Vinod have given that answers. Correct. So I think all of you are right in that way, that a patient who is not actively having bronchospasm, just giving you history. Remember, ketamine is not only safe, but even propofol becomes safe. Okay. Dr. Jana, isn't ketamine a form of ideal GA? Yes, sort of. Ketamine is one drug, as Dr. Chanda says there. Okay, so ketamine is one of the drugs which is also said to be like a street anesthetic agent. You know, so you're walking on the street and you want to give anesthesia, so it can be used. In fact, since we are discussing ketamine, might as well discuss the complete properties of ketamine also. As I said, anesthesia drugs are all used and abused. You know, each and every drug is abused. So when you speak of ketamine, okay, one more point now. I want to ask another question. May I? People do this and this. I want to ask, may I do something? Yes, guys. एक और question कर ले. Which of the following is correct regarding ketamine? A. Ketamine produces which type of anesthesia? So I made the question here itself. Distributive, dissociative, differential, none of the above. Okay. Ketamine produces which type of anesthesia? Okay, so that's how questions get asked in the exam. Since we're discussing, might as well discuss this point out. So Dr. Julie, Dr. Andy, Dr. Deepak, Dr. PK. All right. Okay, so cool. All of you gave me the correct answer, dissociative anesthesia. So that's the property of ketamine. Ketamine produces dissociative anesthesia. All right. So what is dissociative anesthesia? So basically when you give ketamine, it causes thalamocortical, correct, Dr. Krishnan. All right. So it causes dissociative anesthesia. Basically what it is doing is it's causing a thalamocortical limbic dissociation. Okay, it's causing a thalamocortical limbic dissociation. Because of this, there's a dissociation in the brain. One part gets depressed, one part gets stimulated. So the brain does not know what exactly is happening. Because of which, in a patient, you not only get analgesia and anesthesia. Analgesia, anesthesia. You also get amnesia in the patient. It also produces sedation. So do you realize analgesia, anesthesia, amnesia, sedation, all are getting produced by one drug called ketamine. And that is why a lot of people also say that ketamine is supposed to be sort of a complete agent. In the old times, the complete agents used to be ether and chloroform. The same thing which they show you in movies, ether and chloroform. Alright, but they were inhalational agents. Nowadays they say ketamine is sort of a complete agent. Important point, the same respiratory system. It takes care of analgesia, anesthesia, amnesia and sedation. At the same time, it kind of maintains the respiration. So it's not just a good bronchodilator, guys. It also causes the least respiratory depression. It sort of maintains the respiration. That's exactly why a lot of people called ketamine to be as one of the agents that is a street anesthetic agent or a complete agent. Thumbs up all of you. Point clear? Point clear? So let me know. Then we'll go forward to the next question then. Yes. Okay. So let's start with the next one. Okay, so let's start with the next one. Which of the following produces a maximum greenhouse effect? I think there is some lag that takes place now between the time when I'm asking you and when you give me the answers. Okay, so there was a good question from Dr. Chanda coming there. Isn't ketamine a form of ideal GA? Yes, sort of. Absolutely true. So, but then, however, we don't prefer it because of the side effects which are there. Anyways, one more question. No, chodo yaar. Let me just tell you that those are the hallucinations basically because of which we don't use it. Next question, let's do what we were already typed in. Which of the following produces the maximum greenhouse effect? Okay, so please say, is it ether, enflurane, halothane or nitrous oxide? Important question है आज के ज़माने में nowadays. If you don't answer, वो that Nobel Prize winner, she'll be at your house. You know na, what's her name? I think the one who had given a Nobel speech. No, not Nobel speech. That Nobel Prize winner, I forgot. They stand with placards, na, they'll come to your house. Greenhouse effect, greenhouse effect, greenhouse effect. So I think most of you again, yeah, Dr. Vijay, Greta, right. So people will come with the placards to your house if you don't answer this question correctly. You're supposed to be aware of or conscious of the environment, what we are doing. The point is, nitrous oxide, correct, absolutely. I think all of you, in fact, most of you have given me the correct answer. Here the answer is nitrous oxide. This question has been asked many times in exam. Nahi, Malala nahi. Dr. Andy, Greta. Malala is not for greenhouse effect. She was for that women's rights and all. Okay. Anyways, those are not MCQs question, but just deviating from the topic and trying to come back. So we were discussing the greenhouse effect basically. So greenhouse effect means environmental pollution. So ether, enflurane, halothane, nitrous oxide. Remember, inhalational agents are the ones which are getting released into the atmosphere. See, IV drugs का क्या होता है? When you use drugs like thiopentone, you use drugs like ketamine, they will go IV, they will go into the liver, and from the liver they will get metabolized, kidney, they get excreted and they move out. The problem is drugs like nitrous, halothane, enflurane and ether, when they come out of the patient, they are coming out into the atmosphere. In fact, when you're there in an OT of general anesthesia, if you people are interns and post-interns, if you're there into OT of GA, Medical College Government Hospital, oh, Dr. Andy, Greta को Nobel Prize नहीं मिला. अच्छा ठीक है, sorry, I take my words back. Okay, that is not MCQ question. तो ठीक है, I take my words back. Talking about GA then, I was saying when you're taking drugs like halothane, when you're given halothane to a patient and suddenly you've given GA and you're standing in the OT for GA for maybe 6 hours, suddenly you start feeling sleepy, is because whatever the patient has left in the atmosphere is what you are breathing for those 6 hours. So you feel sleepy. So do you realize any inhalational agent that you are giving inside the patient is also coming out of the patient, and it is coming out into the atmosphere, which is not only causing OT pollution but also causing environmental pollution. How did that happen? It's because not with ether, enflurane, and halothane so much, but nitrous oxide is one gas which is actually decreasing the ozone layer. Okay, so therefore nitrous oxide basically is decreasing the ozone layer, because of which it is causing the environmental pollution. All right, so the point is, if that is the case, why are we still using nitrous oxide? Nitrous oxide is used, guys, because of the property. May I ask the question, why is nitrous oxide? It's a gas which was discovered in 1773. Today is 2022. Why is nitrous oxide still being used? Remember, ether was used in the year 1846. Now it's outdated. We don't use ether. But nitrous oxide in 1773, today is 2022, and nitrous oxide is still used because of what? Wait, I'm giving the answers. Correct. So, because of vasodilation, correct? Because of Fink effect, because of being Venturi effect, or because of or working as a carrier agent. Let's take it A, B, C, D. Oh, so all of you have given me the answer also. Okay, so anyways, the point was to discuss this over here. Was it because of vasodilation that it causes? Why it's being used? Because of Fink effect, because of Venturi effect, or carrier gas effect? Correct. The correct answer is D, because of being a carrier agent. It works as a carrier of inhalational agents. Okay, it works as a carrier of inhalational agents, because of which nitrous oxide is still used today. Correct, all of you, absolutely correct. So this is not the correct answer. Yes, galat hai. The correct answer is carrier of inhalational agents. It is still being used, though it was discovered in 1773. Today is 2022. The problem with nitrous oxide is it is causing environmental pollution. That's exactly why people want to replace it. Next MCQ question. Okay, so which of the following can replace nitrous oxide? Please mark your answers now. Based on that, which of the following can replace nitrous oxide as a carrier gas for volatile anesthetic agents? हाँ डॉक्टर गुरु का एक आंसर आया मेरे को. डी. अदर पीपल? I thought this was the easiest question, but I think most of you have marked the wrong answer here only. Okay, other questions I was still I thought you people might have got confused, but no, I thought this was supposed to be the easiest till now. Let me see the answers, other people, what they are giving. Mark your answers fast, yeah, all of you. So good. There are two of them giving me the correct answer till now that I see. Dr. Apple B. अरे ये भी सही नाम है यार, कल के तरह. Today I didn't get Dr. Staphylococcus. I told Dr. Staphylococcus that I'll be here. Dr. Sundar says A. Sundar Hari Prakash. So right, Dr. Julie, Dr. Sundar Hari Prakash, Dr. Apple B. Correct. I am Bumblebee. Apple B. I am Bumblebee. Yesterday I was Staphylococcus, I was Streptococcus. Today I am Bumblebee. Tomorrow's class will be held by Dr. Bumblebee. I am done. कल से मेरा नाम Bumblebee. Anyways, all of you who marked the answer A correct is correct. Huh? Xenon is the correct answer. Remember, that's exactly why this question comes in exam. Okay, the drug which can replace. Why you want to replace nitrous oxide? Because nitrous oxide is basically causing environmental pollution. Because of the environmental pollution, greenhouse effect that it is causing, you want to replace nitrous oxide. You want to replace nitrous oxide because nitrous oxide is still being used today as a carrier agent. What drug can replace it? Okay, the drug that can replace it is xenon, because xenon ideally, as Dr. Julie says, most ideal anesthetic gas. Correct, it has got the same effect. It is almost the same as nitrous oxide. The properties of xenon are almost the same as nitrous oxide, so people are doing research on that. The problem is that xenon is expensive. Okay, xenon X is expensive. Okay, because of this reason, basic reason, expensive, no anesthesia machine is available. That is why xenon is not used. But otherwise, right, xenon is supposed to be the most ideal anesthetic agent, and it is the agent that can replace nitrous oxide as the carrier of inhalationals. Okay, helium. Okay, since we are discussing helium, is there a role of helium in the medical profession? Where is it used? Anyone? Why did I discuss helium? I have written carbon dioxide. I can also say हाँ time pass में लिखा था like yesterday. But yes, helium has a role in medical profession, even carbon dioxide. So tell me, helium, where it is used? Helium. Where is helium used? Helium. Where, guys? Helium and carbon dioxide. So let's talk about helium first. Then we'll discuss carbon dioxide. Yes, anyone? Helium. See, helium is lighter than air. Okay, it's lighter than air. So it can go inside any tissue. Dr. Hemant says, sorry to interrupt, when is your class starting for FMGE batch which started on 12th Jan? Dr. Hemant, I don't know exactly. मेरा batch FMGE का I think वो next time होगा शायद. I think so. So Dr. Chan saying, if we face issues in clearing carbon dioxide, no, that will get absorbed in the bloodstream while doing lapro. So I'm just coming to that point. First, let's discuss helium. Then we go to, I'll just clear the doubt, Dr. Chanda, for you as well. Okay. Dr. Hemant, I don't remember exactly. देखना पड़ेगा. Dr. Hemant, just follow me up. Telegram ID पे message करो, then I'll see. ठीक है? I'll let you know which branches I'm there. Right, Dr. Amit. Absolutely correct. Helium is combined with oxygen. Correct. Heliox, in fact. Absolutely correct. And this is used for, this is lighter than air, it goes up. So therefore, if someone is having lower airway obstruction, like someone is having ARDS, someone is having hypoxia, someone is having burns, जिसका सांस में नहीं आ रहा, दिक्कत हो रही है, bronchial asthma, okay. So all the patients having lower airway obstruction where oxygen is not going inside, you can use helium or heliox. It can be used for ARDS, burns, bronchial asthma, and apart from that, it is also used in patients in deep sea divers, nitrogen narcosis, you must have heard. This is again that miscellaneous question that comes in the exam. Deep sea divers, those people who dive in the deep sea, they normally come up with this nitrogen narcosis. So helium is used for them. Okay, so helium or heliox is used there. What about carbon dioxide, guys? Carbon dioxide normally दो जगह use होता है. One is laparoscopy, correct, as Dr. Guru was saying, pneumoperitoneum, basically when you're doing a laparoscopy case. Okay, and it can be used for laser also. All right. So these are two places where carbon dioxide is used in the medical profession. Color of cylinder. Let's ask helium. What is the color of cylinder? Carbon dioxide, color of cylinder. Okay, let me only give you the options. Okay, let's do it like this. Helium. I'm giving you color gray with white, let's take brown, and let's take orange. Yes, color of helium. नहीं. Color of helium. Dr. Andy, sometimes things can go, it can be wrong. Helium cylinder color. Till now, there's only one person who's given the correct answer. Very nice. Orange cyclopropane says Dr. Guru. Correct. Dr. Julie says. Correct. Dr. Julie and Dr. Sundar Hari Prakash. Correct. Brown is the correct answer. Helium cylinder is basically brown in color. Okay. Right, Dr. Andy, that was xenon and it is white in color. It's not even gray. Gray is basically carbon dioxide. So again, this is important question, right? Remember, yaar, cylinder colors are very important. Don't have confusions. Remember like this, air. Color of the air cylinder is always gray with white shoulder. Okay. When you speak of oxygen, again, the whole world knows that. पूरे इंडिया को पता है. COVID के time पे we have seen ना, it's black with white shoulder. Okay, then you see nitrous oxide. It is always blue in color. Then you go for Entonox. Entonox is nitrous oxide plus oxygen. So it is blue with white shoulder. Okay, and then let's talk about carbon dioxide. It is gray in color. Helium, it is brown in color. And normally if you have heliox, it can have that white shoulder. So brown with white will become heliox. And the orange colored is cyclopropane. So these are the, Dr. Kalpana says A. So okay, so gray was carbon dioxide. This is what we had said. Gray was carbon dioxide in the previous thing which I had mentioned to you. So these cylinders of each and every gas is important for the exam purposes. Air is gray with white shoulder. Oxygen is black with white shoulder. Nitrous oxide is blue. Entonox is blue with white shoulder. Carbon dioxide is gray. Helium is brown. Orange is cyclopropane. अरे उल्टा हो गया. Sorry, I should have done it like this. नहीं, helium तो ठीक है. Cyclopropane is orange. So let's change it like, sorry. So I'll make it like this, cyclopropane. Okay, so let's discuss the pin index also. Air is 1.5, oxygen is 2.5, nitrous is 3.5, anthrax is 7, carbon dioxide हाँ डॉक्टर अमित आई नो डायरेक्टली फोटोज आर कमिंग बट यू जस्ट हैव टू बी अवेयर यू नो तो नाम तो वही रहेगा ना यू आर राइट सो लास्ट टाइम आई हैडंट प्लान टू डिस्कस दिस पॉइंट आउट बट सिंस यू पीपल वर सिंस आई आस्क्ड दैट क्वेश्चन सो आई थॉट माइट एज वेल डिस्कस इट आउट फॉर द एग्जाम पर्पसेस यू नो okay okay so when you speak of carbon dioxide 1,6 and 2,6 is carbon dioxide, helium would be 2,4 and 4,6 and cyclopropane is 3,6. However, helium and cyclopropane are not very important from exam point of view, they won't be asked so much, but the first 4 and 5 are important. Air, oxygen, nitrous, anthrax, carbon dioxide are important. Thumbs up all of you, clear? So we discussed the cylinder colors and we discussed the pin index also, important point. I had not thought of putting up this question today, I did not. But since we were discussing, I thought might as well discuss it out. It's an important question for the exam. Thumbs up all of you, clear? Okay. So a lot of us have doubts, you know, normally what is the pin index and what is the color of cylinder. Every time this question comes, you know, every year, every second year, this question is there. Some cylinder or some pin index is always there. Okay, so going forward, so this is basically white in color, guys. It's not gray. I don't know how the photo is coming, but normally xenon cylinder has to be white. It is not gray. Okay. Okay, so let's talk about propofol. Which of the following is seen with propofol? The next question. So mark your answers. Okay, so I can see most of you have marked the answer A. Okay, till what I can see over here. Other people, there's so many of you. So Dr. Sameer, Dr. Chandan, Dr. Vinod, and Dr. Andy Sky, wonderful, absolutely great. Unless until you know the properties of propofol, you can't answer. Dr. Meangum Explorer, सही नाम है यार, मतलब great, nice, good name. So all of you people who mark the answer C, absolutely correct. Unless and until you know individual properties of the drug, you'll not be able to answer this question, and that's how it comes in the exam. Remember, when we discuss propofol, guys, remember propofol is a very good anti-emetic agent. It is actually used for treatment of vomiting. Vomiting is not a side effect of propofol. Propofol, fall of everything, it does not cause hypertension. In fact, propofol will cause hypotension. P for propofol and P for profound hypotension. Hypotension means falls in blood pressure. You give propofol to some, how to identify propofol? There it is. This is propofol, white color. White color is propofol. This is what comes in the exam. White color emulsion, Dr. Amit. Okay. This is propofol that you get. Okay, it's an emulsion, comes out in white in color. Okay, so this is propofol. When you see propofol's properties, what does it do? Remember propofol, whether you speak of CVS, whether you speak of CNS or you speak of RS, it's going to decrease everything. So in the CVS, it decreases the heart rate, it decreases the blood pressure, it decreases the cardiac output. CNS decreases intracranial pressure, cerebral blood flow, decreases the cerebral metabolic rate, respiratory system decreases the respiratory rate, decreases the minute ventilation. In fact, it causes apnea in the patient, immediate. It also decreases the airway reflex, because of which it's a drug of choice for intubation or LMA insertion. So therefore you will find that propofol here is not going to cause hypertension, it can cause hypotension. Propofol's property, it's an anti-emetic agent, therefore it does not cause vomiting. You know, it's just like how I used to do when we were in Pharmac, na? When you have Viva in Pharmac, and they say take this drug. Side effect, nausea, vomiting. Ondansetron side effect, nausea, vomiting. You say perinom side effect, nausea, vomiting. Then you realize, oh, it was ondansetron which is used for treatment of vomiting. I don't know whether you people have undergone that or not, but when you're sitting for a Viva in Pharmac, because you remember that nausea, vomiting so much that any drug causes, because बाकी property side effect तो याद नहीं रहता ना. The only side effect that you remember in life is nausea, vomiting. So someone says ondansetron used for treatment for vomiting. Side effect, nausea, vomiting. Then someone will say metoclopramide, side effect, nausea, vomiting. Someone will say pantoprazole, side effect, sir, nausea, vomiting. उसके बाद फार्मेक वाला बोलता है समझ में आ गया. They have understood. Because you have by hearted side effect of nausea, vomiting for everything. Pantoprazole also nausea, vomiting, yeah. You know, all of us have uttered that in the exam. I don't know whether you people have gone through that or not, but there are students who do that. Okay, unknowingly. I didn't say deliberately. Unknowingly, because this nausea, vomiting stays at a face. कुछ भी हुआ तो nausea, vomiting. Treatment of nausea, vomiting, putting finger inside the mouth and vomiting. That is also not treatment of nausea, vomiting. एक नया treatment है वो. Okay, there are people who do that also. Yes. So there is a new treatment apart from ondansetron, metoclopramide, pantoprazole. PPI induced ulcer. अरे हाँ, that can be there, Dr. Amit. लेकिन ultimately वैसा nausea, vomiting नहीं होता है ना. It's not a side effect. Okay, you will not say inducing ulcer becomes a separate thing altogether. All right, but it is not a side effect per se of any of these drugs which are used to treat nausea, vomiting. All right. Similarly, finger therapy doesn't become a nausea, vomiting. Treatment for nausea, vomiting, domperidone, yes, all of them, right? So similarly, remember, propofol is an antiemetic drug. So that doesn't mean for people who are from second year, कि सर ने बोला था propofol is a treatment of antiemetic, is an antiemetic agent. So therefore, घर पे किसी को उल्टी हो रहा है, propofol लगा दो. अरे, you will become Michael Jackson. Don't do that. Okay. So Dr. Andy is saying putting finger and vomiting, right? That's what is another treatment. Okay. So anyway, so when we're discussing, right, Dr. Juliel, I'll tackle that question. Just give me a second. When we discuss propofol, I said it has got antiemetic properties. Remember, another important point, it has antipruritic properties. Okay. It doesn't cause pruritus. It can be used as antiemetic and antipruritic. But the point is, propofol is an IV induction agent. If you give it to someone at home, look at the respiratory effects and cardiac effect, patient तो मर जाएगा. Look at the respiratory effect and cardiac effect, where it is used. It is basically used in the post-operative care. Okay, it is used in the post-operative care. In post-operative room, someone starts vomiting, and for that I can use propofol in small doses as an antiemetic. In the post-operative room, someone starts pruritus. I can use it as an antipruritic agent there. Okay. Last point, active metabolite. Remember, propofol is a drug which actually produces inactive metabolite, because of which it is preferred. So when you come to the liver properties of propofol, when you speak of liver, like what does it do? It undergoes metabolism in the liver. Okay, the metabolism is rapid, it takes place. All right. Apart from that, 70% metabolism takes place in the liver, but remember 30% also goes away from the lungs for propofol. So propofol has got extra hepatic metabolism also, hence it's a drug of choice for a patient suffering from liver disorder, renal disorder, okay, old patients, anyone you can use him. Propofol can be used anywhere. All right, all these patients, so maximum it's the drug of choice. So metabolism, rapid metabolism, it produces inactive metabolite. All right. So therefore, this is the reason also when it's having elimination T half is hardly 1 to 3 hours. Because of this, again, it's a drug of choice for daycare surgery. In fact, the drug maximum uses propofol only 1 to 3 hours. Okay. So now guys, coming back to what, so the active metabolite again is the wrong answer because it produces inactive. Apnea is correct because this is what it is producing. It decreases respiratory rate, minute ventilation and produces apnea. So this is seen with propofol, apnea. You don't get to see vomiting, hypertension, active metabolite. One question Dr. Julie has asked, and I think that's an important and a relevant one also for propofol. At what level of infusion? So Dr. Julie, there's no level of propofol. I'll tell you what happens when you speak of propofol infusion syndrome. So remember, propofol is also the drug of choice. So can you see propofol that you see is also the drug of choice for ICU sedation. All right, it's a very good drug. So now what happens is, drug of choice for ICU sedation is propofol. So if you use it in every patient for ICU sedation, is it going to cause propofol infusion syndrome? No. So what happens is, if you're using propofol as a drug of choice for ICU sedation, especially in a pediatric patient, okay, and this patient is in the ICU, no doubt, and the patient is on an infusion of propofol for sedation. So what happens is, remember, what are the contents of propofol? You people would be knowing the contents of propofol is egg lecithin, soybean oil, and glycerol. है ना? Egg lecithin, soybean oil, and glycerol are the contents. Imagine you started a pediatric patient in the ICU on an infusion continuous going, which contains, soybean oil, glycerol, egg lecithin, and this after going for 24 to 48 hours. So that is the answer to your question, Dr. Julie. It's not immediately. When you start an infusion which is going for 24 to 48 hours, especially in a pediatric patient in ICU, imagine that baby is getting so much egg lecithin, so much soybean oil, so much glycerol. So what happens is that there is a failure of the free fatty acid metabolism that takes place. Okay, because of the failure of free fatty acid metabolism, what has taken place? So all that Krebs cycle which you people know, all right? So the end product is that lactate, so accumulation of that lactic acidosis. So therefore it leads to accumulation of lactate causing metabolic acidosis. This can cause cardiac changes. So it leads to cardiomyopathy in the patient. Skeletal muscle changes leading to skeletal myopathy. So muscles get involved there. Okay, so metabolic acidosis, cardiomyopathy. So basically imagine the baby's function, the liver, kidney is unable to, basically take care of the free fatty acid metabolism that is. So failure occurs. The metabolism of the free fatty acid, that failure takes place. This leads to metabolic acidosis, cardiomyopathy, skeletal myopathy, and this leads to cardiac failure, liver failure, hepatic failure, renal failure, and this is what is called as propofol infusion syndrome. Thumbs up all of you, point clear. This much is sufficient for you people to know. You don't need to know anything more than this for at your level right now. Okay, Dr. Julie, is this point clear? Propofol infusion syndrome. Again, important question from NEET PG point of view and INI-CET. Dr. Guru says sevoflurane metabolite is compound A. Haan, correct. That is correct. Okay, Dr. Guru, absolutely correct. So right, so I think we have finished this point also. Let's take one more question, guys. All right, so Dr. Julie, hopefully your doubt is also clear. Remember, propofol is white in color, and not just propofol. I've also discussed before, etomidate is also white in color. Okay, etomidate is also white in color. Don't get confused. It's not just propofol. Even etomidate is white in color. Okay, both. Anticonvulsant in nature. Which of the following? Dr. Kalpana says carbon dioxide in laparoscopy. Correct, for pneumoperitoneum, na Dr. Kalpana? What's your question there? Okay, so I think most of you have marked the answers C are correct. Correct. So let's see ketamine. Remember guys, ketamine per se in the CNS is always contraindicated. It increases the cerebral blood flow. It increases the cerebral metabolic rate. Okay. All right. It increases the intracranial pressure. So anything to do with brain, ketamine is out totally. Okay. It cannot be done. Methoxytol and thiopentone, remember both of them are barbiturate. What's a barbiturate? So you people must have read phenobarbital. No, A is not the answer, guys. A is not the answer. The correct answer is C, thiopentone. So remember, barbiturate are the drugs that you people know are phenobarbital. You people have studied this in pharmac, you've studied this in medicine. Okay, so phenobarbital. So phenobarbital is used for treatment of epilepsy, neonatal jaundice. It is used in few places, right? So it's long-acting drug. All right, long-acting drug hai ye. However, in the same barbiturate group, the short-acting drug, both methoxytol and thiopentone, these are barbiturates but short-acting. Phenobarbital would become long-acting. Dr. Mani, Lakshman and barbiturates are sleeping pills? Nahi. Basically, benzodiazepines are more of sleeping pills. That alprazolam and all those things, everything comes from that benzodiazepine. But these are the same group that you study in pharmac, that pharmac chapter of sedative and hypnotics. So when you classify that in KD Tripathi, that's how it's given. You classify them as benzodiazepines. There are other ones also, and barbiturates. So in benzodiazepine, you will get all that midazolam, you will get that alprazolam, you will get clonazepam. So all these are the drugs which are benzodiazepines. Of course, all of them have similar properties. These are all sedatives and hypnotics. In barbiturates, you have long-acting, intermediate-acting and short-acting. So long-acting is that phenobarbital which I was telling you, and short-acting you have thiopentone and methoxytol. So phenobarbital is used for treatment of epilepsy. So thiopentone also might be the same. So you will say methoxytol also. Yes, it might, but this is the only difference between methoxytol and thiopentone, that both of them are barbiturates, but thiopentone, like phenobarbital, turns out to be a very good anticonvulsant agent. In fact, thiopentone can also be used for treatment of status epilepticus. It is such a good drug. In fact, not just status epilepticus, it's such a good drug in the CNS that it can also be used for treatment of raised intracranial pressure. All right. Methoxytol, on the other hand, is not anticonvulsant, but methoxytol turns out to be a proconvulsant drug. Proconvulsant का मतलब होता है it can actually cause seizures. Because it can cause seizures, it is used in a patient of ECT. I think all of you have mentioned also. I think Dr. Julie has mentioned that. It is used in a treatment, not treatment, but you're giving shock to someone. Electroconvulsive therapy, like how they show in Hindi movies. Salman Khan is like this and 10 people are holding him and the doctor comes like this and gives a shock. Wrong. They don't know medicine. So many things shown in Hindi movies is wrong. 10 people is not holding when someone is giving a shock. You always give a drug. So guys, methoxytol was the drug of choice for ECT in psychiatry before giving shock to someone, because it was a proconvulsant drug. It was causing seizures in the patient. Okay. However, it is not used nowadays because it causes HPA axis suppression. That's the side effect. The side effect of methoxytol is HPA axis suppression, and yes, that nausea, vomiting. No doubt nausea, vomiting is a side effect here. Okay. So HPA axis suppression and nausea, vomiting are the side effects of methoxytol, and it is not used nowadays for ECT. However, still in books, it's supposed to be one of the best drugs that could have been used. But it is not anticonvulsant. So the only anticonvulsant here that you see is thiopentone, which is a very, very good anticonvulsant. It is used in not only in like for anesthesia, it is in fact also a drug used for narcoanalysis. Where did I see thiopentone recently? I'll tell you where. You people have seen Dark Desires. There's something called as Dark Desires. Recently I had seen some clip from there, someone forwarded. And it has shown the same thing, thiopentone. You will read. So thiopentone is again a drug which is used for narcoanalysis. Okay. So status epilepticus, all right, and treatment of raised intracranial pressure. So thiopentone is one of the best drugs that can be used for CNS. All right. So here the correct answer, anticonvulsant in nature, is thiopentone. So guys, that brings me to the end of the session. Thank you for joining me, guys. Thank you so much. Any questions or doubts, do ask me. All right. So that's my Telegram ID, Dr. Vinish. You can get in touch with me. If there are any questions and doubts, you can ask me there. Any question right now, I'm there to solve it out. All right. So people who have not downloaded the app, please do download the app. You can follow us up there and you will come to know when our next sessions are going to be held. Okay. So thank you, Dr. Meangum, Explorer, Dr. Mani, Lakshman and Dr. Amit. Okay, thank you all of you for joining me at the session. Okay, So Dr. Dawood, Dr. Dashu, Dr. Sundar Hari Prakash, Dr. Andy, Dr. Leo Raj. What magnesium? Yes, Dr. Leo, what's your question? First tell me that. Regarding that, what is the question? What about magnesium sulfate? Where? Magnesium sulfate where? मैग्नीशियम सल्फेट का रोल बहुत जगह है यार. डॉक्टर चंदन, थैंक यू डॉक्टर दाऊद, एवरीवन. So yes, you are right. Yes, it's used everywhere. See, magnesium sulfate nowadays has role in many places. Yeah, see, not only in terms of you might use it in a patient of eclampsia. All right, you are nowadays using it even for neonates in terms of brain development. I don't know whether you people are aware of this thing nowadays or not. They are using it for protection of the brain protection. I think for neonates also they are using. Not neonates. In fact, patients who are about to deliver, I'll say for preterm. For preterm patients also, pregnant ladies are given magnesium sulfate. For eclampsia also it is being used. All right. In convulsions, you're saying neuroprotective. See, from anesthesia, forget about other point. From anesthesia point of view, see, we will not include it like this. Neuroprotective, yes, it has a neuroprotective effect. Na? That's exactly why it is used in preterms. But remember, magnesium sulfate does not have any anesthetic effect per se. If you want to use about a neuroprotective drug that comes from anesthesia, you will have to speak about just thiopentone, you will be speaking about propofol, and you will be speaking of all those drugs who are benzodiazepines like midazolam, diazepam, lorazepam, alprazolam. So these are neuroprotective drugs. Okay, and magnesium sulfate does have the neuroprotective property because of which you're using in preterm patients. Preterm because they're neuroprotective towards the brain protection in terms of neonates. When they get born, the preterm, when they expect the babies to be born in neonates, use of magnesium sulfate is said to be protective towards the brain. So many times pediatricians, the NICU specialist, they are advising to start magnesium sulfate so that in the preterm ladies, when the neonates are going to get born, preterm neonates, so in those patients, it was going to protect the brain for them. All right. In fact, I remember magnesium sulfate and all is even started in tetanus patients and all. Okay. So magnesium is something which has to be very careful because that level of toxicity, the tolerance level, it is very small level where which you can get complications occurring with magnesium sulfate, especially when we are giving it IV. All of us are using magnesium sulfate IV. So you have to be very careful. That margin of error is very, very less with magnesium sulfate. One has to be very, very careful. Okay, so you have to monitor the reflexes properly, the CNS symptoms properly. You would be knowing, you have to take that thing to see the reflexes in a patient. All right, when you're working in the ICU, you'll realize that you have to measure those reflexes in the patient just to see कि hyperreflexia नहीं हो रहा है magnesium से. All right, so otherwise, yes, it is neuroprotective, but from anesthesia point of view, doesn't come as an anesthetic drug, no doubt about it. Okay, from anesthesia point of view, it is thiopentone, propofol, and benzodiazepines, which we call as neuroprotective agents. Take everyone. Dr. Dashu says narrow therapeutic index. Correct. I did not get that word. Thank you for putting that word in my mouth. Okay. Now I'll keep it inside. I'll not throw it away, Dr. Dashu. Thank you. Okay. Therapeutic index was the right word which I was looking for. I said margin of error, safety. I said all those words. Dr. Dashu gave me the exact word. Narrow therapeutic index. Okay. So that's how. Good. Well studied, huh? Alright, guys. So all the best. Do well. My Telegram ID is Dr. Vinish. Any questions or doubts, you can ask me directly. Alright. So thank you for joining me at this session and all the best to all of you. Take care. People who haven't downloaded the app, download the app and you can follow us up so that you come to know when next sessions are there. Bye. All the best. Thank you. Thank you all of you. Thank you so much. Bye. Bye guys. Thank you all of you.